Well, a very warm welcome to everybody to today's online event, which is the awards for the Strategic Impact Award Clinical Audit Awareness Week. So this is run by HQIP and Healthcare Quality Improvement Partnership, and these awards are scheduled to end at 1:30. So my name is Chris Gush. I am the Chief Exec of HQIP, and I'm going to be the host for the lunchtime event here. So firstly, can you please note this event's been recorded? I'm going to hopefully make the slides and the recording available online on the HQIP website in due course. It'd be quite good to go back to some of these. This event is part of Clinical Audit Awareness Week, and it's a week-long campaign that is actually across many organisations at the moment, and it celebrates and promotes the critical role of clinical audit awareness and data in improving healthcare, and importantly, improving the experience and outcomes for patients and those that are delivering care. So thank you all for giving up your time today. What I'm just going to explain, so today's part of 5 theme days across the week. The 2026 campaign explores how insight becomes action, showcasing practical examples, innovation and collaboration to support improvement across healthcare. And today's theme is turning strategy into reality. It's of critical importance if we're to realise the ambition set out in the 10-year plan and other key strategies by using healthcare data to support the delivery of national programmes. We can deliver a sustainable healthcare service that ensures resources are used where it benefits patients the most. So next slide, please. Thank you. Now the admin bit. Before we start, a few brief housekeeping notes. All microphones are auto-muted to avoid any background noise. Cameras can be on. After all, we're a community. It'd be great to see everybody, but be free to turn them off if you're having lunch or if it's preferred. The chat function's been turned off for this event because we're using the Q&A function for you to be able to post questions to the speakers. So there's going to be a dedicated Q&A at the end, and opportunities to put questions to our speakers points throughout the session. So please submit your questions. Press the Q&A button at the top of the screens. Microsoft have advised it's best to use a laptop or PC, not a phone. So for the full experience, I think you should be using the browser version of Teams if possible, not the app, to get that kind of webinar experience. If you have any problems, try going across to the browser. If you're unable to access the Q&A function, please contact us through the contact form on the website, and we'll be able to pick them up there. If there's any technical issues throughout this session and the webinar ends earlier than expected, can you wait around for about 30 seconds and then rejoin by clicking the rejoin button on the screen via the original link, and then we'll hopefully be able to get everybody back in the room. We do encourage everyone to share the event and the activity that you're running in your own organisations up and down the country during Clinical Audit Awareness Week on social media using the hashtag CAAW26. And we're really trying to shine a light on the importance of all the work that we're doing across national clinical audit outcomes programmes and registries and activities that are linked to that. And so it'd be great to get that going more broadly. Next slide, please. So today's award announcement is around the strategic impact category. So this celebrates projects that demonstrate the power of clinical audit and data-informed improvement to deliver real change at scale. These projects align with the national priorities, support the ambitions of the 10-year plan, improve outcomes for patients, and help ensure that the limited resources directed where they can have the greatest impact. Today we're going to hear from some teams who have move beyond measure to use evidence to shape services, influence decision making, and deliver some lasting improvement. Slide, please. So, as any good award starts, the runners up are. Next slide. Urology Prostate Cancer Pathway Team at Ashford and St Peter's Hospital NHS Foundation Trust. This team looked at service redesign and capability improvement through nurse practitioner role expansion and prostate biopsy pathway. So congratulations. Next slide, please. And the joint runner-up is the Improvement Networks team at NHS Elect for the thrombosis in acute stroke. Next slide, please. So, drum roll, and the winner is, next slide, it's Dr. Aicha Bouraoui on behalf of the Adolescent and Young Adult Rheumatology team at the University College London Hospitals. Pathway to equity from barriers to bridges. Congratulations to Aicha. Next slide. So I'd like to welcome Aicha to come and give a presentation on her work.
Thank you so much, Chris and team, for the kind invitation. It's a great honor to be with you all today and present on behalf of our team the Pathway to Equity project and share the lesson we learned over the last few years. I'm Aicha Bouraoui. I'm consultant rheumatologist and divisional medical information officer at Lewisham and Greenwich NHS Trust, and honorary consultant in adolescent and young adult rheumatology at UCLH. Next slide, please. So this work has been sponsored by the CAAW community. We were very fortunate to have 3 awards over 2 years, but we're also very grateful to the support we received from UCLH Transformation Team and Population Health Board, especially in relation to the evaluation of the project. There are no conflicts of interest to declare. Next slide, please. So the journey started with a question, which is why young people are not attending their clinic appointments. At UCLH, we have a high rate of clinic non-attendance, especially in children and young people divisions, which has a very significant impact on individual patients, but also on other patients waiting to be seen. It does cause significant waste of resources in the system, with over 1 million annual loss for UCLH just for CYP divisions. But also it does have an impact on clinicians and admin colleagues with significant burnout trying to fit in these patients, and overbook an appointment has been the new norm. Next slide, please. So beyond data, there are young people's stories, and this is one of the stories that I wanted to share. BL is a 23-year-old young person living in Camden. She lost both parents, lives alone, and she has a very complex autoimmune condition called lupus, which whereby the immune system mistakenly affects different parts of the system. She does have skin problems as well as joint issues, and she is under multiple teams, including rheumatology, dermatology, gastro, hematology, but also having this long-term conditions, living in significantly difficult social circumstances has had an impact on her mental health. She suffered from depression and anxiety. She was not able to continue with education. And over 1 year, she had missed several hospital appointments, but as a result of that, her condition deteriorated and she required several hospital admissions, which again impacted further on her mental health. And the cost per capita, the cost for this young person at the system level was about £53,000 a year, between hospital admissions, missed appointments, and so on. Next slide, please. So the Pathway to Equity is a journey that started with taking time to understand the system using data in young people's story, because without understanding the problem, it's very difficult to actually address it. And importantly, we cannot just quick fix recurrent issues in a very complex system. So we really wanted to take our time and make sure that we deep dive into the problem in order to develop a strategy that is meaningful, that is relevant to young people, but equally create an opportunity for collaborative working across the whole system and move beyond siloed working. Next slide, please. So we used one of the tools, is called iceberg model. So at the top of the iceberg is the event, which is non-attendance. And then we use data to learn about patterns. And that was quantitative work stream, where we used several variables and we did several analysis, including use of machine learning. And we also wanted to deep dive further using qualitative measures, whereby we worked with young people to deep dive into the kind of complex, systemic and cultural issues. Every single step in this journey has been with the relevant people in the room, importantly, young people, clinicians, administrators, business intelligence team, in order to co-produce our journey in an authentic and meaningful way. Next slide, please. So starting with data, we looked at several variables, initially ran logistic regression analysis, which identified that distance, index of multiple deprivations, followed by distance from hospital and past history of non-attendance as main predictors. Next slide, please. But we did further analysis using machine learning and feature importance, which revealed similar patterns, whereby index of multiple deprivations followed by distance and past history of DNA and age were the main predictors of non-attendance. So overall, we had an idea about the predictors, and we were able at this stage to stop and just develop a prediction model and identify a list. But we didn't want to stop there. We wanted to deep dive into the deeper structural and cultural issues that get in the way of young people accessing care. Next slide, please. And as I mentioned, we're very fortunate to have patient and public involvement strategy in place in our departments. So we involved 9 young people using our service along with healthcare professionals. And the whole qualitative journey has been co-produced with young people, from writing scripts and planning for our interviews, contacting young people not attending clinics, to co-facilitating, co-organizing an engagement day at UCLH, whereby we got young people, healthcare professionals, parents joining the workshops. And we had also an artist as part of our journey who co-produce illustrations with us to convey the main messages from the initial learning. And at this stage, we had 2 work streams. We had the contacting patients, so interviewing young people not attending, and the engagement day. But we've noticed that there is a theme coming in each work stream, which is schools. So we added an extra work stream, which is working with school students. Next slide, please. So as part of this process, we engaged with local schools, but we used one process to help us achieve 2 goals. We knew that young people struggle with accessing quality work experience, especially health and social care students. And what we did, we invited young people to be part of quality work experience, and in return to be quality improvement partners as part of the Pathway to Equity projects. And as part of this process, we delivered 3 workshops, 1 in-person workshop in schools, talking about career in the NHS. And then those who wanted to get involved, they were our quality improvement partners. You can see example of badges in the slides. And they were using their badge, they co-designed surveys, and they asked their peers in relations to, what's their experience with the NHS. If they had an issue going to hospital, what are the different problems and barriers? How do they see how an NHS system or a health system should look like for them? How can they look after themselves, and what gets in the way of them looking after themselves? And then after a few months, we had a 3rd face-to-face workshop at UCLH, whereby young people, along with the school students, came together to share learnings and identify ideas. How can we develop our strategy as part of the implementation phase? Next slide, please. So as I mentioned, we are very fortunate to have support from the population health boards and transformation team to do independent analysis. So the thematic analysis was done independently. And there are 4 core themes that came out from the analysis from both the patients' interviews, engagement days, as well as the school surveys. So what gets in the way of young people accessing care? There are practical barriers, including transports, and also going for a long journey to the hospital is tiring. It does exacerbate symptoms, especially for those with long-term conditions, chronic pain, and so on. And also sometimes there is practical issues around the booking system, also missing information, along with life, because there are competing priorities in life, looking after yourself, along with attending your schools, along with sometimes planning for works and jobs, even during the summer holidays, especially for those young people from deprived area, all of which can get in the way of them attending their appointments and accessing care. There are also communication issues, language. You use lots of jargon in the NHS that make it difficult for young people to understand how to navigate the system. And there is also siloed working, which gets in the way of continuations of care for patients with long-term condition, whereby different providers don't share the informations. Young people with long-term condition face stigma, and there is a lack of awareness, especially when it comes to rare conditions like patient we see in adolescent rheumatology, and they find it difficult to explain that arthritis affects young people, is not just an old person disease, and that stigma impact on their perceptions of health, their relationship with their long-term condition, self-management, and the way how they engage with the system. And we should remember that these are young people who go naturally through a complex transition, physically, psychologically, and socially as well. Right, next slide, please. So as I mentioned, we had the third workshop whereby all young people, teachers, school students, patients, and healthcare professionals came together, went through the data, and we identified ideas to guide our strategy in terms of the implementation phase. One of the key ideas of how can we use data to identify vulnerable patients, but also how can we develop a system in place to allow reminding patients as well as flexible scheduling opportunities. Representations and sensitivity in clinics was a key issue, especially for the diverse needs of young people. And also young people made it clear that they need to see a system where it's not just about healthcare, but a system that think more upstream in terms of prevention and in terms of working more collaboratively with other institutions like schools. Next slide, please. So guided by this strategy, we had 4 work streams. The first one is in the downstream worlds, whereby we use data. We developed a prediction model for clinic non-attendance, and this prediction model was enhanced to identify patients at risk of not attending their clinic. Then at the higher level, we wanted more personalized, empathetic, non-judgmental approach that can help to engage meaningfully with young people. And as part of this pilot, we included the role of peer support coordinator scheme, whereby the peer support coordinator gets in touch with patients and young people at risk of not attending clinics, build a relationship with them, have one-to-one calls and check-ins, and signpost them to resources that get in the way of them looking after themselves. But we didn't stop just in the downstream world. As per young people advice and recommendation, we had to move a bit more upstream. And what we did, we piloted a place-based health promotion hub in schools. So this is again the same idea, using work experience as a mechanism, whereby young people in schools, they develop their leadership skills, they run regular workshops in their schools to help with mental health, but also health promotions and accessing supports. And it's all run by young people, supported by teacher and healthcare professionals. And in between, we had a resource hub that linked the upstream and downstream worlds. And this is the population health that was co-produced as well with young people and school students as part of their work experience. Next slide, please. So as I mentioned, we enhanced our non-attendance prediction model to make sure that it can be applied to all specialties, not just to adolescents and young adult rheumatology. And I'm pleased now it has been applied across all outpatient settings at University College London Hospital. Next slide, please. Along with sending a list, we also send guidance to teams, including script, how you get in touch with patients, how you approach them in personalized manner. And also we co-produced a travel toolkit to help the callers signpost to patients who are not able to travel to hospitals. Next slide, please. And the outcome so far as part of this pilot, we have with sustainable peer support, along with data, we managed to reduce our clinic non-attendance. A sustainable support can provide 66% of reduction in non-attendance, and we managed to achieve the lowest rate of non-attendance to 5.2% from 15% in 1 year. But it's not just the numbers, it's more about building trusted relationship with these vulnerable patients. And this is what our peer support coordinator did. So she does one-to-one check-ins and calls, and she organized also a peer support hangout space whereby young people with long-term condition come together and talk about navigating health and life while living with long-term conditions. Next slide, please. So our peer support coordinator had engaged with over 600 vulnerable young people. She developed also a hangout space, which is a digital platform whereby young people come and talk about life and living with long-term conditions, and all of which led to estimated saving of £76,000 in adolescent and young adult rheumatology. Next slide, please. So going back to our young person story, so she was identified through the non-attendance prediction model. Delaney, our support coordinator, got in touch with her. She did one-to-one calls. She also discussed her case in our multidisciplinary team meeting, and she worked closely with community partners, like GPs, social prescribers, and we managed to signpost her and support her with resources that are relevant to her. Over 1 year, there was no single acute hospital admission for this young person. She attended her appointment with the right support she needed, and she is back to education. She's currently studying in college. Next slide, please. So I'm sharing here some of the feedbacks that young people provided as part of the one-to-one calls. These are young people identified through the prediction model. And as you can see from the feedback, it's not just about attending an appointment or transport support. It's more also about how can we build a trusted relationship and empower young people to take care of themselves. Next slide, please. I'm here sharing some feedback with from young people who are part of this project as quality improvement partners, and how they felt about being part of it and driving improvement for their peers. And next slide, please. So as I mentioned, we wanted to move beyond the downstream world, and we tested our upstream intervention. So during the workshops, we had 2 schools who were interested to test this. And the school that are currently continuing with the pilot is Haringey Sixth Form, and they organized workshops, but also they have organized also as part of the space, a space for remote consultations for those who don't need to go physically to hospital, waste half day of education or sometimes a whole day, and they can just have 15 minutes permission from their class to attend an appointment in their own school in a safe space. Next slide, please. So as I mentioned, the health space is young person led and all done as part of work experience. So every hour counted as part of organizing or planning for it is counted toward their quality work experience. And they did everything from the actual proposal, outcome measures, KPIs, different activities. And we worked closely with Haringey Public Health as well as local colleagues to help deliver this work stream. Next slide, please. And the Youth Healthcare Bridge, this is the resource that was co-produced by young people as part of work experience as well. We produced it on a time banking platform called HQIP, whereby all time spent as part of this project is counted toward quality experience. And in return, young people can connect with thousands of healthcare professionals for mentoring or support as part of planning for joining the NHS. And as part of this, we managed to develop Resource Hub. We do, this is like you can access it through the link, but also please give feedback and share any ideas if you feel that we need to improve the Resource Hub in any way that you feel can meet the local young people. Next slide, please. So we started with the journey looking at the question, why young people are not attending clinic? We didn't want to fix the problem. We challenged ourselves not to rush to quickly fix it, but importantly, to deep dive into the problem, listen to the people's stories and hear from them. And together we managed to identify ideas that take us from traditional model that reactively address problems to more proactive NHS that work more collaboratively with the community and the people we serve. So we expanded our potential to more innovative measures that actually help beyond fixing healthcare problem to more addressing other issues like equity and access and quality work experience, for example. Next slide, please. So we're very fortunate to be recognized by the Health Foundation, also as Global Top 30 Improvers as part of the International Forum on Quality and Safety in Healthcare, presented our work in the Core 20 Plus Ambassadors Program, and very fortunate to join today, wonderful colleagues as part of the Clinical Audit Week, and very grateful for the opportunity. Importantly, what I feel very proud of is the achievement that young people being part of this project has got. They received awards in their schools, and we have young people who are currently joining the health systems from nursing, physiotherapy, which is absolutely wonderful. Next slide, please. So this is an acknowledgement for the amazing team who worked behind the scene to deliver this project. And I'm very grateful to every single clinical admin colleague, as well as improvement team to CLH, business intelligence, and most importantly, young people who have been at the heart of this journey. Next slide, please. And thank you everyone for listening. I'm very happy to be contacted directly and very keen to share learning. And if you are keen to replicate the project, please get in touch. Thank you.
Aicha, thank you very much for that. That was a fantastic presentation, and it's amazing to hear all the work that you and your team have done. Not only your output in improving the attendance rates, but that relationship across the system and the relationship with the young people that you developed and the influence you had on their lives outside of just the healthcare relationship, but also onto their careers, back into school, back into college. It's really inspiring. So congratulations. If anyone's got any questions, please do put it in the Q&A, and we'll have an opportunity slightly later on to come back with some questions. So as many of you will be aware, in her former remit as NQICAN chair, Vicky shared some reflections on each of the award categories in previous Clinical Audit Awareness weeks. And with the feedback we've got was fantastic on these, and they are always very well received. So Vicky's kindly offered to continue to offer the kind of local clinical audit perspective in her own capacity for this year's event. So over to you, Vicky.
Oh, lovely. Thank you, Chris. So just to confirm then really quickly, I'm working across acute and community services, obviously supporting teams to deliver clinical audit that actually drives that real improvement on the ground. And it's obviously, as part of Audit Awareness Week, so important just to say that clinical audit isn't just something we do. It really is something that should actively drive change. And we've just heard about that in the today's award winner. So we really need to focus on what matters, because the NHS is absolutely not short of strategy. And obviously today's event is around looking at how we can make strategy happen in reality on the ground. But what we do need to do on the ground is make sure that we are actually delivering the strategy it impacts, and that we can actually then evidence that it's working. And that's really what I want to touch on to today over the next few slides. So we know here that the NHS is focused on these three major shifts. So it's hospital to community, treatment to prevention, and that analogue to digital. But all of that is actually going to require some measurable change in practice. This isn't just about policy. And this is where clinical audit will show us whether change is actually happening on the ground. So it moves beyond assurance to identifying that variation, driving that action, and linking that evidence-based standards to real patient outcomes. And that's where clinical audit really comes into its own. So this is how audit turns strategy into delivery. It provides that clear, measurable evidence that change is actually happening. So if we could move on to the next slide, then we'll just have a look at how we can bring those 3 NHS shifts to life then. So if we look here at hospital to community audits that track those pathways across those settings, we're reducing those admissions, we're improving discharge, and we're ensuring that continuity of care across any healthcare setting. If we look at treatment to prevention, then audit is supporting that shift to proactive care, which again we just touched on in that example that you just heard from. It's about strengthening that early intervention, it's improving that long-term condition management, and it's ensuring that people are absolutely supported to stay well, which fits with that the ambitions of the 10-year health plan. And then obviously analog to digital, where we're starting to use that audit data, real-time data, to monitor performance and enable that faster improvement. So ultimately then, audit provides the evidence behind delivery. We're driving improvement, reducing that variation, and we're proving that impact. And then across every health and care setting, clinical audit enables that shift from reacting to illness to proactively supporting people to stay well. So we identify that risk early, we intervene sooner, and we're helping people to live healthier, more independent lives for longer. So if we move on then, we'll have a look at then what that means for clinical audit teams and frontline teams on the ground as well. So this is about maximising impact. So we actually need to focus on what genuinely drives improvement across all health and care settings. So that means fewer higher impact audits aligned to priorities with a clear focus on outcomes, not just activity. So audits should support the earlier identification, as we've just touched on, timely intervention and safer, more effective care. And that's whether that's in hospital, community, primary care, mental health services, or for people at home. So to deliver this, we need that strong project design, we need that clear accountability in place, and we need that consistent re-audit to sustain improvement. And just as importantly, it's that triangulation then with patient safety information and data we know, patient experience and outcomes data to help us identify those themes, target those actions where it matters most. And that's how clinical audit moves beyond assurance. It becomes that proactive tool to drive change, reduce variation, and deliver those measurable improvements in outcomes. So then how do we demonstrate impact and value? If we can move to the next slide then. Firstly, audit must clearly show then that we've improved in practice and outcomes. So thinking about some examples then, like that VTE compliance, moving it to above 95%, which is the NHS England standard now, reducing medication errors through those medicines reconciliation, and then strengthening things like falls or harm prevention, which is relevant across any care setting, including home. Secondly, it's about looking at that unwarranted variation that you've heard about already in today's session, and then further areas such as things like wound care and discharge processes and that preventative care. So it's supporting more consistent, safer care across our services. Now, we know that our own boards and the CQC back in your own healthcare setting, they're driving for their evidence that we're aware of variation and we're looking to address it both in terms of equity and access. And then obviously that critical improvement in terms of it being sustained. It means that we do need that re-audit, we do need to move to that continuous measurement, like your statistical process controls, where we're actually tracking real progress in real time over time. And then finally, all of that should provide us with that robust evidence for our CQC and our governance frameworks as well. So it's showing that improvements not only achieved, but we've maintained it. And ultimately, that is clinical audit turning data into assurance and assurance into measurable, sustained improvement in patient care. So if we move on then, we can have a look at some of the key takeaways from some of those key messages for you then. So firstly then, audit must demonstrate impact. It must clearly show what's improved in outcomes and care delivery. So it does include things like improving those individualised care plans for the patients, that timely follow-up, that long-term condition management across all settings. Secondly, audit reduces that variation that we've touched on. So we're identifying the differences in care, such as referral responses, wound care and prevention, and ensuring more consistent and equitable services. Thirdly, it must provide robust evidence. So we're giving assurance to our teams, our boards and our regulators that actually improvement is real, it is sustained, and it's increasing through that continuous measurement. We don't just stop. And finally, then it does drive that accountability. So we're actually using our data to inform decisions, that shared decision making that supports integrated working, and it actually strengthens system-wide governance. So the expectation is quite clear, I think, here. It's that focus is on high impact priorities, use your data proactively, ensure that every audit does deliver sustained improvement in outcomes, and it's outcomes that are closer to home, which fits then with the ambitions of the 10-year health plan. So ultimately, clinical audit will help us to turn that strategy into measurable impact, delivering better, more consistent care wherever our patients are. So if we just move to the final slide then, and I'll sum up all those key points then. This is about positioning clinical audit as that true strategic enabler of NHS transformation. So the focus must be on impact, not volume, delivering measurable improvements in outcomes and quality of care. And that does now mean aligning audits to transformation priorities and using it to provide clear evidence that change is working. So whether that's improving pathways, reducing variation, or actually supporting new models of care. So audit is now going to give our teams the opportunity to lead on the improvement. They'll be able to identify gaps, test those changes, and then embed better ways of working. So just to set a little bit of a call to action for you all, as we always do when we're in Audit Awareness Week, it's to ask you all now to think about focusing your audits on what matters most. Use your data proactively, and then make sure that every audit counts by delivering that real and sustained improvement. And ultimately then, audit is how we prove that change is real and that strategy is being delivered in practice. So thank you for listening.
Thank you, Vicky. That's really brilliant to hear, and I think that use of driving and using audit to help deliver the 3 shifts and that impact to improvement is spot on and essential, and actually a narrative we will need to, I think, amplify throughout our organisations to ensure that it is being heard. We've got a bit of time for Q&A, so I know there's quite a few questions come through. Lacia, have you managed to pick any out to ask our panel members here?
Yes, I'll start with some questions for Aicha. So the first one is saying that they loved the person-centred approaches to the project that you took us through today, including the upstream intervention health space. But the question is, do you feel there were wider societal benefits that you've shown today with this amazing project?
Thank you. Absolutely. I think if we think more upstream, we will find a lot of societal benefits, especially when it comes to meaningfully engaging with young people in the community, like having young people interested in healthcare, having by the end of the project, young people, joining universities, presenting their work at the year 13, presenting an abstract in Royal Society of Medicine last year. So I think it's about empowering the people we serve, and actually they can take meaningful part in shaping the health system in a way that is relevant to them, rather than us actually thinking very hard about finding solutions. It's just having the right conversation with the people, with the public, with the patients can help us easily find ideas in way how we can meet their needs, and actually without spending that much. It is far more cost effective. So there are societal benefits in terms of engaging. There are societal benefits in terms of prevention. So these community health promotion hubs in schools could be scaled up to other settings like work settings, local community events could include health promotion activities led by young people themselves. So there are a lot that we can do. It's just having the right conversation, spend time to build relationship and trust. And once that's achieved, then you can get the most of the people engaged in your work.
And then a follow-up question, Chris, if I might. I think this is something for anyone who's working with young people, is just if you could talk people through ethical approvals you needed and what that involves.
So the first part of the project was a service evaluation. we wanted to know exactly what's happened as part of our audit. We had to collect data. It's very much encouraged to seek feedback from patients. So actually, it's part of NHS England guidance. When patients do not attend appointment, it's important to contact them and find out what's getting in the way of them not attending clinic. And also engaging with the public is also recommended in the NHS. So when we consulted with our leadership team, we didn't need to seek ethical approval, and because all is aligned with our UCLH policy. And therefore, patients also involved in our work group are part of an established patient and public involvement governance, which is set up in the trust. So, and I'm very happy also to share, learning for anyone interested to set up patient and public involvement in their hospitals. I'm very happy to share resources. I'm very happy to share resources. How can you develop quality improvement partners with students interested in doing projects, and in return they get access to quality work experience, how you recognize that as well. So we have a lot of resources that we'd be very happy to share.
Okay, and then quite a specific question, as you have been so gracious in your offers, is someone's asking, Jacqueline is asking, do you have any role descriptions or similar for a QI
Yes.
community partner? Something you
We
can
do.
share?
Yes, we do, and it's shared with their schools as well. So everything like the engagements was initially with the schools. So how we got engaged with the schools, it was through Health Watch charities, and they connected us with several local schools. And then when we engaged with them, we co-produced the job descriptions for the quality improvement partners with the students and their teachers. So I'm very happy to share that. I'm also happy to share how you develop the same role with patients involved in your in your organizations, so apart from volunteering, there is also, because volunteering require physical presence in the trust and getting in touch with patients, but we had young people who were not able to travel to come just for half a day or collect feedback, so we created this quality improvement partners for patients as well, and I'm happy to share the job description. So I'll send all those resources to Fiona, and I'm very happy to be contacted directly as well if you'd like, if you have any questions about any part of the project.
And then, if I might, Chris, I could like to bring Vicky into this as well. So this is a question really for both Aicha and Vicky, because someone has pointed out that it's an excellent project, but they would have liked to have it labelled more as clinical audit. But I'm keen that we sort of talk through the idea of clinical audit being part of a raft of ways in which we can improve healthcare. It's part of a mix, if you like. So I wonder, Vicky, if you might have a few words to say about that.
Yeah, I was just going to say, really, I think a lot of it, because really, I suppose you're probably asking, you want to see what the audit standards were on a slide, and I just think actually in terms of airtime when you're presenting back at these award events, you want to really hear the impact, don't you? And this was a combination of service evaluation, clinical audit, and wider improvement data that you've collected and used, and I just think it's a fantastic example of data-informed improvement, regardless of what the type of activity it was. We're seeing more and more projects come through now that are both a mixture of audit and service evaluation and wider QI. And to be honest, they are going to be your more robust projects as you move forward. I mean, Aicha, you referred to some of the NHS England standards around the DNA policy and the guidance that we're given to follow up with people that don't attend. And in terms of looking at your equity and access, I think that's exactly what you've done. So it did come across in your discussion around your project. So I think people just have to understand that actually these are audits, there's audit in there, but what we're trying to do is make the impact of the airtime that you've got when you're presenting it back. And I really wanted personally to hear about the impact and how you achieved it. But then I know that there was obviously audit in there. So I'm hoping that might help some of the audience understand and appreciate.
Thank you. Sorry, guys. Go on.
Just going to say, do you think we have time for one more question, or is it time to wrap up?
One more.
Okay. So actually, this question is just something that I'm getting from across the group, and I'm interested to know, was there anything about working with young people that surprised you, either positively or negatively? So things that were easier than you expected, or things that were harder than you expected?
So so working with young people, how initially it was, I felt it was my own, like, you feel a little bit worried when you do an engagement events with young people, but actually what made things really easy is just creating that safe space and let them run the event and come up. You kind of unlock that potential, and that's what I've done. I found myself, rather than leading the project, I'm actually facilitating things between different team members and help them to realize how creative they are, and and that's kind of empowerment, help to get the best out of them, but also help them to realize that they can achieve a lot. It's building confidence, but they build that confidence as they take us through the journey. So for me, initially, I think it was just me at the start. My story. So when it comes to my training in adolescents health, I took time out of my training to actually be trained in looking after young people, because there is a gap in my training program. And I'm very fortunate that I have worked with teams that work closely with young people, and the way how we did it was amazing. We shifted from engaging with young people in research to actually moving it gradually to service improvements. And so working with young people is not that difficult, as long as you create a safe space, empower them to be part of it, get the numbers right, because if you have 2 or 3 and 7, 8, 9 healthcare professional is not right. So we made sure that we have equal or actually more numbers of young people compared to healthcare professional, because there is that peer-to-peer influence. So one start talking, the other person will start engaging more. And the way how we set up our organizing committee, we had different groups to enable young people to talk with young people and identify ideas. And then they started running the whole qualitative journey. They organized, and co-produced the whole engagement event at UCLH. So that made our job a lot easier, but also more meaningful and authentic.
Thank you very much for that. And I think that's fabulous in terms of the way that you use the data, you use the audit information to actually catalyze those conversations and drive it forward. And that really strikes me when we're looking to take away, what are we taking away from this? It captures exactly where clinical audit needs to be positioned. It's often viewed as a measurement and assurance function, but today it really shows us that its real value is moving beyond that assurance into improvement and catalyzing these conversations, demonstrating impact, reducing the variation, and that robust evidence that you talked about to drive accountability and change and conversations are all essential if we're going to kind of change this strategy that we have to follow into reality. So, I mean, as we pursue that kind of and drive with the NHS's ambition around prevention, neighbourhood health, greater use of technology and data, I think clinical audit really has a critical role to play. We've got many of the skills, and you can see from the presentation those relationships that we need to support that journey. The challenge is really for us to ensure that our work isn't only generating that evidence, but it's actively influencing decisions and change and really improving care. So I'd really like to thank everybody that joined, particularly our presenters, and I look forward to hearing a lot more as the week goes on. So thank you very much.